wonderful to be here, everyone, and you'll get an impression. We'll introduce ourselves again in a minute, just to add a few little details. But I think the key thing about Sarah and myself doing this together was that we're coming from different perspectives. With, at the moment, Sarah working as a lecturer and doing research. She's done research in this area. Myself, as a practicing midwife working in the NHS at the moment, but also me having trained as a midwife in my 40s, having had 3 children, and Sarah and I were discussing it, Sarah having started as a midwife before she had her 2 children. So we were exploring the different angles that might bring to the session as well, and keen to raise more questions probably this evening than we have answers, which is probably the measure of a good question, or a good theme, that we end up with more questions. But we really want to be able to present what we know already, which is very little actually, and then begin to ask questions around it, which I'm sure many of you will have thoughts about. Some of you will have come into this evening having trained as a midwife and then become a parent. Some of you will have been a parent and then trained as a midwife. And so your perspectives will be incredibly valuable, your personal perspectives on this topic. So there's the first slide, just with our names and our contact details on there. And you've heard from Sue, mostly, who I am. I think she said all of that. And that picture is actually me during deep COVID, that second wave, the Delta wave in January 2021, on my son's 18th birthday, after a night shift where I'd welcomed this little boy, shared with permission, into the world. And the reason I've chosen that picture is it represents the motivation for writing the book, which is all about expressing the psychological realities of midwifery. So I'm going to let Sarah introduce herself.
So this is me. So I spent 13 years as a midwife at Leicester Royal Infirmary, and then left 4 years ago to come into full-time teaching, and I love it. I love teaching students. It's my passion. It's definitely where, I see my path going. When undertaking my master's back in COVID, so trying to do a master's whilst homeschooling and working full-time, which was kind of tricky, I became really interested in birth trauma and vicarious trauma that midwives get from witnessing trauma in practice, and also the trauma that they bring with them as they enter the maternity services as a student midwife. So that's how me and Kate kind of got together and ended up on here tonight.
Yeah, we actually met at the Maternity Midwifery Festival in Leicester, didn't we? The Midlands one.
Yes, it was actually one of my students who spoke to Kate and said, you need to come and meet Kate because she's interested in your research and you're talking about the same things. You need to get together. So that was brilliant.
Look how this happens. It's amazing how you can form these connections so quickly. So just to give you a bit of context about the book, because Flourish talks about what I've called the 5 mega mountains of midwifery. You can see them on the screen there: moral injury, compassion fatigue, burnout, trauma exposure, and PTSI as those big themes, the things that we encounter in midwifery, the emotional landscape, as it were. And I started to ask questions about not only vicarious trauma or secondary trauma, how midwives are being exposed to trauma via their work, our work, but also what does it mean to be experiencing personal trauma and possibly birth trauma in the context of already having been exposed in a midwifery environment. So one of the chapters in the book is about midwives as people who also give birth. So it kind of inspired all this thinking, which already since the publication I've discovered more. So there'll be lots in the second edition. That will definitely be an updated chapter. So what I discovered and what I saw as I wrote the book was that midwives were walking around saying, I'm not cut out for this. I'm too old or too tired or too sensitive for this work. And what I knew, having done the research, was actually happening was that there was unacknowledged traumatic stress. And that was the context for how midwives were feeling, and particularly in COVID, very shut down from ourselves and sometimes from each other as well, just trying to get through. But this unacknowledged traumatic stress, in the context of when midwives give birth, can obviously lead to more stress, compound stress and trauma as a result of not really having looked at it. So the book explores trauma exposure and reflects on the fact that not all events that are perceived to be traumatic are objectively severe in their nature. So as in, we might not consider something to be traumatic, but actually it is for that person. And of course, that's true for pregnant and birthing women and people, but it's also true for midwives. And midwives are exposed ongoing to trauma. So it's not just about those events that we would say are classically trauma-inducing, but just being involved in difficult lives of the families we encounter and what they have to go through in their lives, hearing from each other about traumatic events or situations, even if we weren't involved. And then, of course, witnessing or supporting colleagues who are currently suffering, whether that's midwifery-related suffering or life-related suffering as well. So all of those things hold grains of trauma exposure possibility. And then, of course, there are also the big events. So why look at when midwives give birth? I love this quote from Maya Angelou from her book, I Know Why the Caged Bird Sings. There is no greater agony than bearing an untold story inside of you. And as I wrote the book, I really had a sense that midwives have a deeply untold story. Many of us have experienced things that we have packaged up and put aside, maybe talked to a few colleagues about, but we've never really had, many of us, the psychological support to allow that story to be told. And I was very aware that our workforce, the midwifery workforce is getting younger. So there are more 18-year-olds and that sort of age group being trained and educated in midwifery. And very aware, therefore, that the childbearing population they're more likely to have been affected as a younger person, as a midwife, by all of this. And this was what triggered my interest in this area. It was a scoping review of maternity care providers' experience of primary trauma. This is Lisa Charmer and her colleagues in the Gold Coast in Australia, published in 2021. And they looked at 352 relevant studies and found absolutely nothing written about it. And that shocked me at the time. And I thought, how could that be that we are not thinking about the impact on midwives as they go through this vulnerable time of life and are exposed potentially to primary trauma for a second time? So the disconnects in our thinking seem to be these. What on earth is happening that we are not focusing on the emotional health of this large female midwifery workforce? That's the first question, right? Even without the second half of that sentence, why is there an absence of focus on our emotional health? Second part of that sentence, the majority of this workforce will experience this enormous transition during or before their time as a midwife. And also, what's going on that we're not linking, obviously, the emotional health of midwives with the emotional health of women. Now, of course, some researchers have done that. Jenny Patterson, for example, and her team from Edinburgh Napier have talked about the impact of care providers' emotional landscape and the way in which it impacts on women. But specifically around a midwife's experience of giving birth and their experience of midwifery and how it leads to the impact on their birthing experience, at this point hadn't been written about. So profound disconnects and a gap in our knowledge as well. The next slide shows a picture of a health professional there, these lovely images drawn by my gorgeous illustrator, Joe Bradshaw. But this shows a defeated health professional. And the quote here is from Lisa Charmer and her colleagues' study, saying primary trauma personally experienced by maternity care providers during their childbirthing journey is not discussed in the literature. It's feasible to assume that there'd be a significant number of those MCPs as participants in those broader studies about birth trauma, but this is not evident to date. This would suggest that a substantial number of midwives, obstetricians, etc., suffer primary trauma leading to PTSD from their birth trauma, but it's unknown, and then return to the clinical setting. And obviously that was one of my primary concerns as I wrote the book, that there is not just the period of pregnancy and anxiety in pregnancy, which brings midwives to this place of making decisions about their births and about their breastfeeding journeys, but also what does it mean to be returning to the clinical setting with all of that background that you're bringing with you. So, questions around maternity care providers experiencing PTSD. Is that what's happening? And what's happening when we come back into the clinical setting? Are we being exposed to subsequent trauma events? And, having seen anecdotally colleagues coming back from maternity leave and being expected on labour ward to go back into the room where they've experienced personal trauma themselves, there are many ways in which we could prepare for that experience, but then soften it live in the moment when people return from maternity leave. So we're going to offer up some suggestions, but also ask you for your opinions in a bit. So a few mind-blowing thoughts. We don't know whether a midwife is more or less likely to experience personal birth trauma than a non-midwife. The most recent Australian study, which was 2019, around birth trauma, not specifically around midwives, but it did break down the numbers, and it said that 93% of midwives had experienced trauma. It was a small study, 249 people, and within their professional lives, they broke it down like this: 85% had experienced trauma in their professional lives, and 41% had experienced trauma in their own birth. So similar numbers at 41% to the ones that Sheen and Spivey and Slade have always quoted, around 30%. So 30% of childbearing women are experiencing perinatal trauma. So presumably we can only assume that at least 30% of midwives may be carrying an experience of trauma back into the workplace. And that may then create this opportunity for compound trauma. So, in addition to this, we know that women who are from Black, Asian and mixed ethnicity backgrounds are more likely to die in the perinatal period. And we know that they're 2 to 3 times as likely to have a baby who dies in the womb or after birth. And they're more likely to experience care as traumatic, absolutely, because of previous experiences of trauma and of marginalisation in healthcare. None of us need more evidence of that, but what we're needing to do is to pay more attention to those layers of trauma amongst these groups of colleagues, and thinking about what does it mean to be a Black, Asian or mixed ethnicity woman who's also a midwife, who already has more exposure and vulnerability to exposure to trauma. And then on top of that, we're not really doing the work, the psychological work, to enable people to tell their stories, to get the support that they need, and then to be able to reach out in this period of vulnerability in pregnancy and after the birth itself, before a return to the clinical setting. So this study, I was, again, golden moment on Twitter, pointed to this when I raised the question on Twitter around when midwives give birth. And Sharon Stolia and Hannah Dahl and Andrew Sheehan, so Sharon's in Australia as well, and they've done an integrative review, so post the one that Lisa Chalmer had done, of midwives' personal childbearing experiences. And they used 20 articles, that some of which date back some time. And what they have noted from this review is that we need to acknowledge the woman within the professional midwife and the professional midwife within the woman. They've said, actually, even what we've looked at, even these 20 articles, these 20 papers that we've looked at, provide a limited research base, and within them there's quite a lot of anecdotal evidence. So they're saying we need to do more work on this, we need to do more research to really understand midwives' own experiences of birth, and then the way our experiences impact practice. What they found is that midwives felt dismissed, that midwives experienced higher fears and anxieties in pregnancy, possibly even higher than another woman who isn't a midwife, because it was being heightened by that professional knowledge. But the mismatch between that and how they were regarded and listened to was huge. And they've pulled out the work of Sarah Church here, and also Redwood there, which is an older piece of work in 2008. But that was a common theme, that midwives who are pregnant have strong fears and anxieties, and the professional knowledge plays into that. They also found that midwives were questioning their previous assumptions about birth and breastfeeding. This is such a striking quote here. How could I have stood beside those women, so many of them calming, breathedly murmuring, "You can do it, you're doing it," letting them trust me. I knew nothing. I didn't deserve their trust. And midwife described the veil of illusion about birth being torn away, as she, in this case, experienced it herself, and then started questioning, oh my goodness, what have I been doing without having experienced this? And I know this is a contentious issue, and I know that there are midwives who have not experienced birth or breastfeeding, etc., and that's absolutely fine. But we've paid little attention to those who have. There is also that question of trauma more broadly. And in this Sharon Stiliar study, in 6 of the 20 articles, midwives are reporting feeling traumatized and having flashbacks and nightmares and panic attacks, sometimes for prolonged periods of time. You can imagine what the main causes of those were. They're described there. And we know that there's an increased risk post-traumatic experience of PTSD developing, or PTSI, injury, as I call it in the book. But we know also that, or at least we can assume, we're making assumptions here, that midwives who have been pre-traumatized by their midwifery experience and then go on to experience a difficult birth, a traumatic birth, are in an increased risk group for developing PTSI themselves. That makes logical sense, doesn't it? But the research work still needs to be done to really ascertain whether that's true. And then I had a chat with the lovely Anna Madeley, who's doing her research, her PhD research with the Open University. I think she's actually being supervised by Sarah Church, who we just mentioned. She's been exploring women's experiences of making non-normative choices in childbirth. She's not yet published, but she very generously shared some of the findings with me. And out of her 13 interviewees, 6 of them were midwives. And she has noted that, yes, those midwives have been affected by secondary trauma, so witnessing trauma being part of it, but not obviously in their own bodies. But they are making, as a result, non-normative choices, so away from those pathways which we might assume to be the normal ones, for their own pregnancies and births. And sometimes that includes, and Sarah's got an example of this as well, choosing cesarean birth. And that serves the purpose of defending or expressing their reproductive identity. So this is one of the themes in her work, talking about defense or expression of reproductive identity and how complicated that is. The relationship between midwife identity and reproductive identity, so intertwined, and midwives sometimes finding it difficult to separate those two, and that sometimes creating further anxiety or difficulty over choices, trying to step away from the normative solution. And that might be, and Anna raised this point as well, further complicated by raised expectations from others of people who are already midwives, and sometimes created by ourselves, because there's a raised expectation, particularly via social media, around how birth will happen, what breastfeeding looks like, what infant feeding choices you're going to make, etc., etc. So obviously people's lives are more visible if we choose to make them so, and that can create another dimension and complication. So Sarah's going to tell us all about her work about mothers becoming midwives, so mothers training in midwifery.
So yeah, part of my my master's dissertation research was about the reason why student midwives who've already had children then go on to do their training. And with most of the people that I spoke to, their own personal experience was a catalyst for them wanting to come into the midwifery profession. And this was either because they had a really positive experience that they wanted to emulate and share with other people, or because they had a negative experience and actually they didn't want anybody else to go through the experience that they went through. Now, this can be a good or a bad thing. So what I found that it didn't affect their philosophy of care and what they wanted for women, but actually when they went back into the environment where they may have had their baby, or a similar environment to where they had their baby, it brought back very significant and strong and unexpected memories. So a lot of the students that I interviewed actually had a very negative time as part of their own pregnancy journey. And they experienced the trauma that Kate was discussing earlier. So I've got a couple of quotes to share with you. So one student said one of their first births, they didn't really know anything, they felt really out of control, and that's an ongoing theme with trauma. It's a lack of control, lack of choice, lack of compassionate care. One student midwife said that it wasn't her body that was traumatized. She got a healthy baby, she had a healthy outcome, but actually it was her mind that was traumatized. And often what you'll find is that, you know, it's not the big catastrophic negative experiences that women have that leave them with trauma. It's the vulnerability that they feel. It's the lack of control, lack of perceived compassionate care. So, like I said, the majority of students experienced unexpected flashbacks when they went back onto clinical placement. So one student went into the antenatal clinic and she had a flashback because it was where she was told that her child had significant congenital abnormalities, and all of a sudden all those memories came back to her when she was in that place, and she didn't realise that was going to happen to her. There was one student that said that she was caring for a woman who really lost control, and that really reminded her of herself and how she felt when she was going through her own childbirth experience. And there was one student who literally had to leave her placement experience because she went into a cesarean section, and what she saw was exactly what she went through, and it upset her so much that she had to walk away. She couldn't do anything more than get very emotional and cry and leave, because although she wasn't expecting it, putting her back in that situation just gave her all of these emotive feelings. And then this the student in the red writing, I mean, this student is all for physiological birth. She's very passionate about physiological birth, but because she experienced herself a postpartum hemorrhage, she finds it very, very difficult to be able to sit on her hands and wait for a physiological third stage. She's only happy when the placenta's out and the blood loss is minimal. So even though she has all of, you know, this faith in childbirth in the back of her mind, she's constantly thinking, I just want the third stage to be over. She was also left quite traumatized by her own birth, and it does impact women for a long time. It has a wider public health impact. So it affects, so when she goes for a smear test, it can affect women engaging with services. So it's not just in terms of having a baby and their future reproductive choices, or if they go in and they're then caring for women based on their own trauma, it can actually have long-term implications for women's health. One of the things the students also said was that they found that childbirth is very medicalised nowadays, which we know. And I think one of the things we do as educators is we teach them the physiology, the normal, what we should expect. And that's really important to teach them the physiology of pregnancy and childbirth, because if they understand the physiology, they then know when things are going wrong. They might not know what it is, but they know that they need to intervene in some way. But one of the issues with teaching them the physiology in the first year is that we then put them in the lion's den when we send them to labour ward. So in an ideal world, we would want to send all of our students to a home birth team or to a birth centre in the first year, and they would see, you know, how the body is able to labour. But instead, we put them on a very complex environment with women with additional needs, and it does have a profound effect on their philosophy about childbirth. And when you're shown one way of how things work, that then becomes you as a person, because that's all you ever see. And so it's really difficult as an educationalist to then be able to speak to the students and teach them in a different way. What the students also said as part of my research was that they thought they would benefit from a debrief service, because what they wanted to do was disassociate their own experience from what they see in clinical practice, because everybody's birth is unique to them. What you have been through yourself, you cannot see in anybody else. And that's why we always say you don't have to have had a baby to be a midwife. You just have to be empathetic and understand that person's journey. So one of the things that came out of it was that I think it would be really important to be able to speak to students when they come into the midwifery education, to be able to say, okay, well, this was your experience, but that's not anybody else's experience. So what you went through, you need to separate yourself from that. Otherwise, it can have an impact on the care that you provide to women. So when I was doing my background research, I found that there wasn't an awful lot at all to do with student midwives and how they, you know, how their experience affects them going forward in their career. So I had to do a little bit of wider reading. And what I did find was that there is a little bit of research around breastfeeding, and midwives who have a positive personal experience of breastfeeding are more willing to offer support to women. Midwives who hadn't had any children of their own just followed the hospital guidelines quite strictly, which is obviously BF5 friendly. Midwives who formula fed their babies were quite happy and more willing to offer supplementation rather than support women with breastfeeding, which is really interesting. A couple of studies found that people who were raised seeing their mothers breastfeed and their families breastfeed, they had stronger beliefs around the benefits of breastfeeding. So these kind of demonstrate how healthcare providers naturally draw on their own experience when providing care and the choices that they offer to women. And I think this is really important when we're examining midwives that have either experienced trauma themselves or they've seen very traumatic experiences that have stayed with them.
Yeah, thank you, Sarah. So we've formulated some discussion points, which are going to get pulled into the chat so that you guys can reflect on them as well and maybe formulate your own questions from them. And I just want to go through them one by one, just because it gives us a chance all to think, and it might stimulate something for you. So we're thinking, based on what Sarah has said, on how can midwifery education providers take a crucial role to facilitate that reflection. So not just this could make a difference to how you practice your personal experience, but also what would true reflection look like on our birth, our parenting, or our infant feeding journeys for those of us who are already mothers or fathers as we come into the midwifery education journey. And there are great ways to do that. True reflection, whether it's written or indeed more verbal ways to reflect, but some sort of psychological support that really gently and slowly unpacks those experiences, personal experiences, so that we're more aware of them, but also can be more aware what kind of influence they might have and where we see those clashes in practice. And that really, really helps those reflections to disassociate, as Sarah was saying, or to distance ourselves from between our journey and the journey of those people we're caring for. It makes an enormous difference. How might maternity employers support a pregnant midwife to prepare for birth, feeding, or parenting by offering psychological support to unravel the stories that they have experienced in practice? What an amazing thing that would be, right? And what an important thing to say, I'm going to support this employee who's going through this enormous transition themselves, to say, we have exposed you, you have been exposed in practice to all of this. How can we help you unravel that before you go on your own personal journey? And how might maternity systems use the rich opportunity during and after maternity leave, not just for healing, but also for growth? And by growth here, we mean, what would supported reflection for midwives be able to create in terms of midwives integrating their own experiences and then deepening and making richer their care, their practice as a midwife? So do you see, that's one step on. Yes, absolutely healing, particularly if they've had a traumatic experience themselves, and possibly compound trauma from their previous experiences of trauma in the workplace. But also, what would growth look like? How would we make the most of these learnings and then reintegrate them back into practice? So we'd love you to have a look at those questions in the chat and make some comments, ask some more questions, any way in which you can input there. There's a quote here from Flourish, which says the same thing, which says, without that processing we've just talked about, we end up carrying our unprocessed stories around with us and creating armor in the form of scripts, which can lead to blind spots or less openness to others' experience. And Sarah's just said that with the infant feeding literature that she came across in her research. Reflecting well and with good structures and support allows us to integrate our own stories and see the scripts we have developed around them and move into a more conscious relationship with our lives and our work. And that's a rich opportunity for all of us in that time of change. So we're looking at resourcing ourselves and resourcing the midwives around us. And this small steps graphic is from the book, but it's showing that, yes, we can't change everything, but we can take small steps which could make a big difference. And sometimes these steps are really tiny and they begin with just asking the questions. And, grateful for all of you for being here tonight, because you're already asking the questions just by being present. And we've got 2 slides with more questions, more possibilities here. And both of these also are going to be drawn into the chat, so you can have more of a look at them and reflect on them. And actually, some of you sitting there may be midwives who have had a baby or had a feeding journey, and you might have immediate answers to these as we talk about them. So what might have made a difference in your pregnancy, first of all, in terms of processing your midwifery journey or your trauma? What would thoroughly emotionally supported have looked like on your return to work, return to practice after maternity leave? And you might ask yourself, what are you discovering even now, even, many years on for some of you, about how your own pregnancy or birth has shaped you as a midwife? So really interesting, reflective questions. And then what extra support might you choose to seek out? If this is for midwives who are becoming pregnant or want to become pregnant or preparing for a birth now, what extra support might you need? What might you ask for? And in the current climate, when we are, struggling for staff and many units are actively lobbying to bring people on board, these are the kind of questions you can ask in an interview. What are you doing for pregnant midwives who are exploring how to unravel their stories in preparation for their own birth and feeding journeys? And I know that might sound ridiculous, but it's true when we're in a buyer's market, as it were, and it can create that kind of radicalized approach to seeking jobs because you're really wanted out there. What about designing a return to work which is compassionate and trauma informed? And that might involve peers as well as midwifery leaders and PMAs and others. What could we do collectively in terms of bringing together our wisdom and saying, what would a really quality return to work look like? And what else might we need? So we're going to throw that into the chat as well so that you've got a chance to continue to look at those. And isn't this true? It may not always feel like this, but actually vulnerability is our greatest strength. And pregnancy as a time of anxiety and fear for many midwives, as we've seen in the small amount of research we have, and birth itself, postnatal life, the early postnatal period in particular, is a time of immense vulnerability. And the return to work as a transition is enormous in parents' lives from a period of maternity or paternity leave. And this question is really helpful. What do I need, but I'm afraid to ask for in this moment? And that could be true for any of us. This is from the book. It's an adaptation from the book turned into a poster so that it's meant to be like a Sharps injury poster so that we can become more aware through laminated posters of this kind in our sluices and on our corridors that trauma exposure requires a response, just as a Sharps injury requires a response. And we need to know in advance what to do about it and how to get the support that we need. So I'm just highlighting the parallel there between physical and emotional trauma. And then that lovely image of midwives supporting each other